Hey everyone, good morning. Let me know if you can hear me okay. Loud and clear. Fantastic. It's good to be back again. Feels like it's been a long week so far, but hopefully your test went okay. Kind of stinks to have a cumulative exam and then to come listen to me for 2 hours afterwards. It's kind of cruel and unusual if you ask me, but I didn't have a whole lot of input on the schedule, so is what it is. I'm assuming most people are still finishing up. I only see about 3 people on, so hopefully they'll join us shortly. And 10. I don't know where that comes from. I was hoping most people would have finished up their test early and it would take a whole 2 hours. I'm going to spend the first few minutes covering how the course is going to go anyway, so hopefully, or maybe if you could like text people perhaps to let them know I'm going to be starting 10. Hey Jillian, how's it going? How was the exam this morning? Hey Mina. We normally do our cumulative at the end of the semester, so I don't know if that was just like catch up for you guys or what's going on with that. Was good to start. Damn, in one word, yikes. That's always what teachers like to hear about their exams. That's yeah, it's tough when it's cumulative. It's just a lot of information you learn your whole first or I guess second semester, but kind of the first real semester, I should say. PA school. Was so last year. I was a retake, okay. I know, I haven't seen you guys since last year. It's been so long, it feels like. Hopefully we didn't lose anybody. I haven't looked at the roster yet, but imagine we kept everyone. Is that the case? All 30. That's fantastic. Really great. 30 in, 30 out, right? That's the goal. I always like to say 64 out the door over at hope people have just a few more minutes here. It should be available. Oh, I didn't publish the link. Try checking now. Should be there. Definitely not losing the sticky notes. I want to keep those going. If you reload the page, let me know if you can't access it. Okay, good. Fantastic. So I'll go ahead and get started just kind of going over the course. We'll give people a few minutes to hop in before we hit the lecture. And you know, this is all recorded so people can kind of rewind me if they want, but it's just more um, administrative stuff in terms of how the class is going to run. But so welcome back. It's good to have you back here in 2021. Good thing all the craziness of 2020 is behind us, and you know it's just going to be a totally normal, totally great year for everyone. Hopefully, you all can get vaccinated at some point if that's your choice. But anyway, so we're here back doing pharmacology again. You're going to find the course is going to be very similar in terms of form and structure as we did for last semester. So here you have the syllabus, which I posted up. Should be able to see that on the front page of the modules page of the course. And so the only big thing that has changed is obviously the topics that we're covering, but I also wanted to point out the grading scheme that we're using here. Not the scheme, I guess, but how we're going to balance things out. So we took some of the pressure off of the quizzes. I received some feedback that that was probably a little too much, which I understand. You know, it's you don't have to put as much time into a quiz, I guess, as a test. So you know, we rebalanced it a little bit. So you'll have 15% will be with the prescription assignments you're doing, and then 15% will be 3 quizzes, which we'll have at the beginning of class through Canvas using the lockdown browser with the cameras. We'll do that, and then the 3 written exams, which will be through your typical exam software and all that. So that has not changed at all. So that way, at least the quizzes will give you a chance to kind of test your knowledge a little bit without it being so you know, having such a profound impact on your final grade there. So if you have any questions about that, certainly let me know. I did want to go over one thing first in terms of oh, and you can see on the course here, you can see the syllabus, the sticky board, and all the assignment, or the first couple PowerPoints and the first assignment is there. I did want to cover the assignment real quick because that's going to be a little different this time around because instead of just doing outpatient prescription assignments, I wanted to show you how we're going to actually be doing some inpatient orders here, right? So you can see here we have Thor, who is a 12-year-old. We're going to go over the pain medications here. This is the first section we're covering, so we'll be able to see the different types of medications we're going to be using. We already covered nausea and vomiting medications, so a lot of this stuff should be you know, right up our alley in terms of the meds we're covering. And so this is a patient who's undergoing what they call a NUS procedure for pectus excavatum, which sounds like a Harry Potter spell, but basically he is being admitted to the floor after surgery, and he's going to require some inpatient orders, and you happen to be the surgical PA on for his admittance. So basically you're going to have 5 different medication orders to write, but again, you're going to be switching gears and going from outpatient to inpatient mindset. So I wanted to make sure you are kind of aware of what we're looking for in terms of how we're going to write these orders and then how we're going to grade it, right? So let me switch gears and look at the rubric real quick here, which should be posted up on the assignment as well. So disregard the first half of this. This is all for the outpatient orders. The second half of the rubric here is where you're going to get the medication order writing. And so this is where basically you're going to still handwrite all of your orders, just like last time. If it's digital, that's fine, but I want everything handwritten. And then you will be then graded on all the medication orders there. You can look at the individual points for where those are going to be coming from. And then here's an example case that I went through. So we have Peter Pan, who's a 46-year-old man, admitted for bacterial meningitis. He was known to have hallucinations, and then he said, I can fly. But now he's coming in, he's going to need something for, you know, agitation. He's going to need some fluids, some antibiotics, etc. So you can see here, go ahead and write out, you know, the patient's information here. That'll be required there. And then here's how orders would look like. Now, nowadays, you'd be doing this electronically, so this may seem a little anachronistic, but I think it's good to get practice doing it by hand, so that way you get a feel for all of the things that are required for an appropriate medication order. So I use the cursive script here just to mimic doing it by hand, otherwise you would not be able to read my handwriting. So basically here, all you got to do is first off, put on the date that you're writing the orders, put the time that you are writing the orders here. So that way everything is kind of time stamped. So that way people know when you wrote those orders in conjunction with, what was going on with the patient and all that. You only have to write this once. I don't need it for every single order because this is for the whole list of orders. Okay. So just write that once. And then basically, you don't need quite as much information as you would need for an outpatient script. Basically, I want to have the drug, the strength, the either how it's being administered, how often, and how many times, right? As appropriate. So for instance, here you can see dextrose 5% with 0.9% sodium chloride. That's just D5NS with 20 MEQs per liter of KCl. Notice the route is being given here, IV, at 125 mLs per hour continuously. That means that patient's going to get that much fluid per hour continuously until the heat death of the universe, unless someone stops that order, right? But it's going to continue. There's no stop time on it, which is totally appropriate because you're going to go back and reassess that patient the next day and maybe DC it potentially if it's appropriate, okay? Next up, we have an order for lorazepam, which is a med we're going to cover a little bit later on in this semester here. But note, you have the name of the drug. You're putting down how much the dose that you want to give, so 1 milligram. You have the route, IV push in this case here. And then you're giving it every 2 hours as needed. And remember, anytime you write as needed, you want to put the indication here. So as needed for anxiety or hallucinations. So every 2 hours, if that patient's having anxiety or hallucinations, then the nurse may administer a dose of 1 milligram of Ativan IV push. Okay, right? Because these are the instructions to the nurses. Next, here's an example of a medication that you don't give IV push, but maybe we give it over a certain period of time. You'd want to specify that if it's appropriate. So Rocephin, 2 grams IV over 30 minutes every 12 hours. Okay. If it's something that you only wanted to do so many doses of, you could do every 12 hours times 4 doses or whatever the case may be. And similar, vancomycin's pretty similar in terms of that. And then at the end, when you wrote all of your orders, then you just sign it at the bottom, put your credentials, and then you're done. Okay. So you just need a date and time at once for all your orders, sign it at the bottom, and this is one whole complete set of orders, okay? And then people could come behind you afterwards and write their own orders if they wanted to. That's typically how paper charts would work. Okay, so any questions on how that's going to happen or how that should be done? Here's a blank one so you can use it yourself. If you do have questions, feel free to let me know. Let's see. I think those are the big things I wanted to show you from the sort of administrative aspects of things. You'll see the due dates for the assignments and all of that. It looks like we have almost everyone with us so far, so that's pretty good. Any questions so far? If you don't put them up in the chat, you can put them up in the sticky board. That's fine. Madeline is saying, for patients who are NPO, are oral meds acceptable? That's a great question. Thank you for asking that. So typically you'll find the NPO orders do not necessarily refer to PO medications. So you'll find that typically that's going to be an exemption for the most part. However, there could be some cases where you could say NPO including meds or something like that. Or you might see orders that say NPO meds, oral meds okay, or ice chips okay, or something like that, so there are cases where you can make those exceptions there. Probably 9 times out of 10 when someone writes an NPO order, oral meds are fine for the most part. The reason why they're NPO is generally because they may be going to surgery, or maybe their situation is compromised such that you don't want them to have a big belly full of food because they could vomit it or something like that. Oral medications are typically, especially with like a tablet, such a small amount of material that it's not going to be a problem. But that was a really good question. Thank you for asking that. And again, I encourage you all, please ask lots of questions. It helps keep me engaged with you guys in terms of making sure that you feel like you're getting all of your questions answered. It helps me to break things up a little bit, so it's not just me droning on for 2 hours straight. No one likes that, including me. I don't necessarily like the sound of my voice that much. And then again, even if it's like off topic stuff like that, like, I didn't even mention anything about NPO, but it came up and it was a really good teaching point. So feel free to bring stuff up. I really encourage you to do so, even if it's on the sticky board, on the chat, whatever. Because it just makes things more fun and interesting for me, which is obviously the most important bit. Just kidding. It's good for your education. Okay, so I want to start out with our first section here. We're going to be talking about orthopedics and pain management. Now, as it turns out, for ortho, there's not a lot of drugs specific to ortho. There's not a lot of medications that specifically treat like orthopedic concerns, because most of the time it's like a physical thing. Like you broke your bone. Like there's no medications that fix a broken bone necessarily. However, a lot of the side issues that pop up, such as pain, certainly we do have medications for. And so this is a good opportunity for me to kind of talk about pain management. This is a huge issue that we are dealing with in the US in terms of the opioid epidemic, on top of all the other epidemics we're dealing with. But it is certainly a good thing to know about, especially because, as of recently, within the past couple of years, PA's ability to prescribe opioid analgesics has actually expanded, and we'll go over that in a little bit more detail. So I'm not sure if you guys have covered any of that yet, but here's where we're going to touch on it now. So pain management, what is that? Well, basically, someone's having pain, and of course, pain is always going to be completely objective. You can measure it, you can put it on a scale. Not really, right? It's going to be a very subjective thing we're going to find. And it's very tough in order to tell, like, okay, well, a patient's they're telling me they're having pain. Is this even true, right? That could be a challenge in and of itself. They're saying they're having the worst pain of their life, but they don't look like they're having the worst pain of their life. Maybe they're over exaggerating, right? There has been a long history, especially, of people being undertreated for their pain because of providers thinking, well, they don't really need that much pain control. They're not in that much pain, right? So it's very much like a very paternalistic sort of model of medicine for going back for decades, if not hundreds of years of, the provider knows best and patients not having their pain adequately managed. And so probably do a whole documentary on that and the number of people who've been undertreated, unfortunately. But regardless, there's a lot of barriers to getting optimal pain relief for your patients. Some of it's related to the patient, where they may be even fearful of things like addiction, right? They may have undergone a major procedure, but they're refusing opioids because they're like, oh, my aunt or uncle got addicted to that stuff. I don't want to do that, even though the chances for that to actually occur are actually quite low. Or they may be worried about adverse effects and things like that. In terms of healthcare providers, we don't really get a ton of like formal training on this unless you actually go and do, a whole secondary fellowship or residency in this. Like my wife, she did a whole second year of pain management. She spent the entire year just learning about this stuff, right? So, she's an expert at it, but it doesn't mean that people that just have graduated and are working out there know anything, know the first thing about pain management. And so it's very tough, and we don't get a lot of training. So a lot of it's kind of done on the job, so to speak, and it's possible for people to get sort of a lot of preconceived notions of things and whatnot that may provide barriers to getting good training for your patients, right? Or good treatment for your patients. There's also the issues like governmental regulation. You're worried about the government watching everything you're doing and getting, the DEA coming after you and stuff. It could be something like that. And then the fear of getting your patients addicted themselves could be a challenge, and it could be something you could be wrestling with. Do I give this patient pain medication even though they could be at risk for having addiction? Who knows, right? And it could be related to the system. There's a relatively few number of people who do pain management specifically. It could be issues of lack of medication availability. And then also, unless you're doing like really invasive techniques like local nerve blocks and things like that, there's not a lot of good reimbursement for pain management. So it's kind of even though it's so important, we don't really support it effectively with the healthcare system, unfortunately. So, what is pain? That's a big question, right? And again, it's defined as really any kind of unpleasant sensory or emotional experience, which you could probably ascribe to my lectures. But it's usually associated with some kind of like actual potential tissue damage, right? So big thing is subjective. So what the patient's telling you is what the pain they're experiencing is. If you could define some sort of objective scale or measure to measure pain, you'd be a billionaire, right? Because you could fix all these problems here to tell if someone's really in pain or not. And we have to rely on things like how are they describing their pain. They say, oh, my pain's a 9 out of 10, and they're just sitting there calmly talking to you, right? It may not match up with what you would expect someone who's in a 9 out of 10 pain to look like, right? Someone who may have just like have their femur sticking out of their leg. You could imagine they might be a 9 or 10 out of 10 on a pain scale, but someone could just be sitting there quietly and they could also feel that kind of pain, right? And basically, it's kind of whatever the patient says it is, and that's what really runs into issues of people who maybe not telling the total truth when they're experiencing pain, right? It's Odd as it may seem, patients will lie to you occasionally, or maybe all the time, depending on where you're working at. But it is what it is, and so we have to find ways we can try to work around that, right? Anyway, so we have this idea of acute versus chronic pain. Chronic is obviously going to be something that's very persistent or intermittent, but it's going to be happening for a long period of time, especially during certain circumstances, like if they're getting up and walking around, but at rest, it's fine. And when we talk about malignant pain, this is normally due to things like cancer or any kind of terminal kind of illness potentially, like, or kind of a progressive, not terminal, but progressive illness, something like multiple sclerosis, for instance. And of course we can break it down, and you've probably covered this quite a bit already in your class, where you learn physical diagnosis and history taking, where you learn about whether pain is somatic, neuropathic, or visceral. We'll find that somatic and visceral pain is treated pretty similarly, whereas neuropathic pain, because it's derived from the nerves, is going to require pretty different treatment there, as we will see in a little bit. I can see the sticky board in case people have questions. Someone does have questions. Let me see here. I'm switch gears. Someone said, historically, do people do better this semester versus last semester? Is there a different approach we should take? First semester approach was different than second. I would say, with the summer semester, it was all kind of like laying the groundwork for these two semesters here, the fall and spring. So I would, whatever approaches you were taking last semester, if they were working for you, they should continue to work for you this semester. The only hiccup might be is the fact that we're covering different topics. So for instance, if you are not very good with nephrology, for instance, there might be a section that's more challenging for you than others, right? Versus if you're really good at infectious disease, then that might be an easier topic for you. So again, being self-reflective and refining your study techniques is all part of the PA process. So find out what worked for you last semester, keep doing that. And then if you find that there are things that was not working for you last semester, then get rid of it, right? Because as time goes on, you'll see that the pressure kind of mounts with the amount of material you're being exposed to and things like that with other courses. And so it's really important to try to refine your study technique, which should be pretty good by now at this point, I imagine. And so from my standpoint, nothing big has changed here. It's just the topics we're touching on. So probably not the best answer that you were looking for, but is what it is, unfortunately. Okay, so when dealing with types of pain, it's important to kind of differentiate between the acute versus chronic pain patients may experience. Obviously, acute is going to be on the scale of like hours to weeks versus chronic be months to years. Normally with acute, there's like an inciting event or some reason why that patient's in pain. So whether it be like surgery or trauma or something, and the prognosis is pretty predictable, right? If you break an arm and it gets, you put a cast on it and it heals, that pain should go away as the healing occurs, right? And for this, the primary treatment is going to be analgesics to cover them for that acute time that they're experiencing the pain. For chronic pain, it becomes much more difficult because it may not be very clear about why that pain is occurring there, right? It may not be any one inciting event that has led to the pain they're experiencing. Whether it improves at all or gets worse over time is unpredictable. We just don't know in a lot of cases. And so the chronic treatment is going to need to be multimodal, right? So it's going to require a lot of non-pharmacologic interventions, which are tough for people. If you're in pain and we tell you to go to physical therapy that hurts, they're not going to want to do that, right? It can include analgesics, but we oftentimes over rely on those analgesics, and that can become a issue when it comes to things like physical dependency, potential for addiction, things like that. So we'll look at some ways we can try to recognize those things and try to treat around them, right? So as I mentioned, with nociceptive pain, that's really that somatic and visceral pain that we're talking about. Normally, you can define as like sharp, dull, aching sort of pain there. Whereas the neuropathic pain feels very different because it's due to actual damage to the nerves, where they get that burning, tingling, shooting sort of pain with like fibromyalgia or diabetic neuropathies, things of that nature. So, and again, cost, in terms of cost, it's huge, for the world, billions of dollars lost due to the fact these people may not be able to go to work and be able to be productive members of society. And it also has a huge impact on their quality of life. And so that's why it's really, really important that when you're dealing with patients with chronic pain issues to make sure that these other things are being addressed as well. So for instance, like the psychological stress this may put people under, it can really worsen their anxiety and depression. And then that depression can then worsen their pain, which can worsen their, their depression. And it becomes a kind of a vicious cycle here. So it's important to make sure that they are having these other things outside of their pain being addressed, because if you can get those you can kind of help those aspects of things, it will also help with the pain, as you'll see. And so optimal pain management obviously depends on being able to optimally assess that sort of pain, which I'm not going to go into too great a detail here, but this is all things that you'd be asking about on your history taking, right? So your OPPQRST, if that's what you use, there's other mnemonics that are out there, but asking about location, asking about onset, and all of that. I'm not going to belabor these points because you get these elsewhere, and you're probably already experts at doing a good history on your patients. At least I'm assuming you're all experts at this already. One thing I do want to touch on though is going to be the intensity of pain. The pain scales I think are important because it's easy enough to ask, okay, well, what's your pain on a scale of 0 to 10? I like to put descriptors on those because, some people say, okay, well, 10's the worst pain in your entire life. Well, they may not have experienced the worst pain in their entire life. I like to ask them questions like, okay, well, 10 is being, I'm sawing off your arm with a dull, rusty spoon, and a 0 is no pain whatsoever. Where are you at right now? If they tell me that they're at a 10, and I go, you feel like right now, like I'm sawing your arm off with a dull, rusty spoon. They say yes, and okay, well, that's what you're telling me. It's a 10, but it may help put things into perspective, right? Or someone's had given birth before. Perhaps everyone's had birth, I guess, but if you've given birth before, perhaps that could be your set point in terms, or kidney stones, or anything that's like a really intense pain thing that can help put things in perspective for them. So maybe instead of saying that they're an 8 out of 10, maybe once they kind of think about it, maybe they're more of like a 5 or a 6. There was it's kind of an older stand-up thing. You can look it up, but I think it was Mike Birbiglia. It might have been someone else, but as a comedian, he was talking about having pain and going into the ER, and he was trying to figure out what the optimal number was to tell the doctor in order to get pain medication, because he wanted to give a number that adequately said, okay, I'm in pain, I actually need medication, but not so high that they thought he was seeking drugs. And so he figured out that it was 8 was the optimal number to tell him so he'd get some morphine, right? Anyway, so you can check that out. It's kind of funny. But regardless, you can also use other scales as well that can kind of help guide things a little bit. I kind of like the idea of visual analog scales. These are kind of nice because it's basically 10 centimeters, and they have to put their finger on where they feel like their pain is right now. And so instead of being tied to a specific number, you would just basically measure the distance from 0 that they are, and then can kind of go back and measure that again, say after some intervention, like giving some pain medication. The point of doing that is instead of someone being locked into numbers, they always say 6, they can't necessarily like tell exactly where they pointed to before. So it kind of takes away some of that prejudice in terms of them being able to pick the same number every time, right? And you'll find too that people don't do that necessarily because they are drug seeking for any reason, but it could be because they kind of psychologically get tied to that number. Especially some of your chronic patients. My wife experienced this quite a bit at the VA where she did her residency. You have people who would, chronically be at a 6 out of 10 pain scale, right? But, 6 out of 10 sounds like it's fairly painful. And so, they go through and look at their medication regimen. They go through and try to fix all this stuff up. And they go back to the patient and say, how you feel? And he goes, oh, I feel so much better. I feel great. I say, well, what's your pain? And they go, well, it's a 6. The number hadn't changed, even though they objectively told you they feel better. So it's one of those things where, that number kind of becomes part of their identity, because that pain is a part of their identity because they feel it all the time, right? So sometimes that 0 to 10 pain scale can be not the most descriptive, unfortunately. And honestly, we don't have the perfect way to measure this stuff. Other ways you could do it, especially for people who may not be able to necessarily equate or understand the concept of numbers so well, would be something like with pediatrics. So here's an example of the Wong-Baker faces scale, where they say, well, if your pain had a face, what would it look like, right? Kids of a certain age should be able to figure that out and say, okay, well, it looks like the guy who's crying because I'm crying right now, right? That makes some sense. Or if you're doing geriatrics, right? So I'm sure most people have never dealt, or at least at least my age and certainly your age, have probably rarely ever seen a mercury thermometer, but a thermometer scale like this, which older patients may be more familiar with, can at least give them some kind of guide of like, okay, well, I know what the top of this really means versus the bottom. So just little things, especially if they have like dementia or aren't able to really communicate as effectively, they can at least point out how they're feeling at that moment. So, and again, look at the modifying factors, right? Figure out what's worked for them and what hasn't, because if someone comes in and is complaining of pain and you try to give them something that they've already been on before that hasn't worked, they're not going to be too happy about it for one, and they're probably not going to think you know what you're doing, right? So it's important to figure out, okay, well, what's been effective, what's not been effective, so that way you can kind of guide where you're going to go to next in terms of your treatment, right? So someone comes in to the ER and they're complaining of a migraine, which we'll talk about migraine treatment later on, and they say, oh, I've already taken ibuprofen, it doesn't touch it. And then you try to give them another dose of ibuprofen, again, they're just not going to be too happy with the care that they're receiving, right? So you may need to step it up and go to something else that does work for them, okay? And patients will tell you too, like especially if they have chronic issues, like sickle cell disease or migraines, like they oftentimes they know what works for them and what doesn't, and they can tell you, right? Now you'll have some patients who will come in and they say, "Oh, I'm allergic to everything. I can only get Dilaudid. That's the only thing that works for me." That might be something you may want to question a little bit, but for actual things you can look in the patient history and say, okay, well they have a history of migraines. It looks like they've gotten this before. They say it works for them. That makes sense, right? So again, a lot of this is kind of using your detective skills, looking at the history, looking at the documentation you have to make a better decision about how to manage that patient, right? I'm not saying every patient's going to lie to you. Some of them will. I know this may be news to some of you, but trying to break you out of your naive little bubble and say patients may lie to you. I'm just kidding. Obviously, I'm not calling anyone naive here, but I was actually pretty naive when I got into it. When I started doing toxicology and dealing with patients who had overdosed, I'm like, why are these people lying to me? I'm trying to help them. They're lying to me all the time, and it was kind of a tough pill to swallow, so to speak. No pun intended. Anyway, so again, when you're doing these histories, making sure you're looking at things like medication history is super important. They may be on medications it's exacerbating their pain. Could be medications that is, making things worse or better. So that's why it's important to assess this. Labs are going to be important for certain medications to check for organ function. Make sure that you're not dosing things too aggressively. And then history of substance abuse is important as well, to ask about things like, not just them, but also family history, because certainly there can be some genetic links to addiction and things like that and substance abuse disorders. And so that's why it's important to try to assess for that if you can. And again, a lot of these patients are going to have concomitant psychiatric issues, anxiety, depression, bipolar disorder, schizophrenia. Like there's a lot of things that could be happening on top of the pain they're experiencing. Those could just be compounding things, right? So you may want to make sure those are also being dealt with at the same time as you're trying to manage their pain, right? Tough dealing with people. They're so complicated. You got so many different things going on, but you got to be the practitioner there to help them out. Now, when dealing with pain, and honestly, I should probably have my wife give me this lecture. She'd probably do it better than I could, but you guys probably like her better too. But anyway, so when dealing with pain, it's important to understand that it's not just like a constant level all the time, right? It will go through peaks and valleys, and it's important to try and manage those peaks and valleys too. So this is especially more for like on a chronic pain sort of issue here. But you can imagine this red line with the pyramids here are going to be the pain that you're experiencing. Could be a baseline level of persistent pain that they're always experiencing, but based on different things like activity, for instance, it may peak up at certain times and go from, say, a 3 up to a 7, right? I get up and I had to go to work. It was a 7 all day, and I got back home and it was fine, right? That's why it's important to make sure that we have treatment for both the persistent pain and then also for what we call that breakthrough pain. So when that pain peaks up, we have something on top that can manage that. So that's why frequently you're going to see patients who are on multiple medications, ones that may be used for around-the-clock treatment for that persistent pain, and then we also have as-needed medications for the breakthrough pain. So we try to go through both those modalities, because the problem is if you just gave them stuff to treat that baseline level of pain, but you never manage these peaks here, well, what are they going to do? Well, they're probably going to start self-medicating, right? So they could start taking over-the-counter stuff, or they could start taking more of their around-the-clock medication to manage that. And that's where people really run into problems of physical dependence and addiction, right? So we want to make sure that we're addressing all these peaks here, because if we don't, then you're going to find that they can spiral out of control in some cases there. Let's see, a couple questions here. Thank you for asking questions. I love this. Someone said, how do you treat chronically ill patients who need the drugs but are at risk for addiction? Example, sickle cell patients. Yeah, that can be tough. Ideally, you're going to try to use as sort of like minimal amount of opioids as possible. We'll get into the different habit forming or addictive medications here in just a little bit and getting more detail on that. But some patients are just on chronic opioids, right? So you may have patients with sickle cell disease that are on, for instance, like Tylenol number 3, which has codeine in it. They may just be on that around the clock for a good amount of time, and then if they come in for an acute pain crisis and you kind of step up your game a little bit and can use some bigger guns, so to speak, in terms of narcotics. But yeah, so ideally, though, you try to wean them off and go to the least sort of intense therapy as possible, but which may not be the case depending on the patient there, especially how well they're managed with everything else, especially with sickle cell patients. If they're not really being adherent to their medication regimens and things like that, that could preclude or, could increase their chances of having an exacerbation and requiring more pain medications. I've seen some cases of sickle cell patients where they would come in and they're coming in for an acute pain crisis, and they're like, okay, well, we've been taking your medications, and then they do urine drug screen on the patient, and they were negative for opioids, and they're like, well, wait a second, where are these opioids going? And it was actually going to the parents. Parents are taking it and selling it or using it or whatever, so it can be a really tough sort of situation to deal with. Someone said, how do you manage patients with chronic conditions that built up a tolerance to the most potent pain medications? I will talk about that a little bit later on, but basically, go up on the dose. We'll also look at some other regimens we can try as well, but most tolerance to opioid medications can be overcome by giving more opioids, and so I'll give you some examples of that a little bit later on. But ideally, if we can use other modalities that do not include opioids, that's going to be ideal. Okay, so back to the chat. Madeline was saying, if they have a history of substance abuse, will we follow a lower dose regimen, or how do we document in our county so that they do not relapse because of us? So we'll get into that a little bit later on. Basically, and actually, not me personally dealt with this, but there was a distant family member who actually is like a wife's a wife of a distant cousin's dad or something, so a very distant relation. But I was hearing about how that person had to undergo open heart surgery because they had a congenital issue from when they were an infant, but in the intervening years they've had a substance abuse issue, right? So the question is, okay, well, you're cracking open their chest. Sounds pretty painful to me. And then you're worried about pain management for this patient because you don't want them to have a relapse due to their substance abuse issue. So we'll look at some adjunctive medications that we can use to try to minimize the number of opioids we're going to require for these patients. That's the ideal thing we can do, is to try to use other regimens, other modalities, to try to avoid as many opioids as possible. Okay, so that's going to be one of my main things we're going to talk about here, is that it's good to know what your options are. Good to have these medications available, but also it's important that we don't overuse them and try to limit how much we are using in these patients here, because a lot of people get overprescribed these opioids because they are so effective at what they do, but they don't necessarily think about the consequences down the road, right? Or people are going about their own means of getting these medications. But anyway, so talking about how we actually decide how to manage these patients here, there are different sort of approaches to how you can do this. There's one like the pain ladder from the World Health Organization. You could also do more of an etiology-based approach. But you want to think about it as like, okay, if you have two people coming to the ER, one person stubbed their toe. First off, you'd be like, why are you in the ER? They stubbed their toe and they're here to get pain medication. And then you have someone who broke their femur and is now currently sticking out of their leg. Obviously, one person's pain is not going to be the same as the others in that case there, right? And so it would be inappropriate to treat them both the same in terms of the pain medications you're giving. Now, this may sound completely obvious to you, but again, I like to make things very clear for everyone just in case. Make sure we're all on the same page. So it's important to consider, okay, well, maybe for the person who stubbed their toe, I can start off with something a little bit weaker in terms of analgesic activity. Maybe something like a Tylenol and ibuprofen. That would probably seem reasonable. I would not want to give that person fentanyl, for example. And we'll talk about all the specific opioids later on. The person whose femur is now sticking out of their leg and they're screaming in pain, if I give them a Tylenol, they're going to be very mad at me because that's not going to do anything for them, right? I need to go ahead and step up my game and go with something that's going to be a little bit heavier hitting, so that way that patient is not experiencing the worst pain of their life, right? So that's why we need to take things into context. That's why you're going to see different types of procedures may require different types of pain management. A laparoscopic cholecystectomy is going to have less pain associated with it than a spinal fusion procedure, right? And so you'll get a feel for that, especially going to surgery, of like, okay, well, how painful are these things? What kind of regimens do we need to do to make sure these patients are being managed adequately from a pain standpoint? Someone asks, are there any legal obligations to telling other providers about known or suspected medication abuse? How does this communication process usually work? I'm going to hold this on here. I want to talk about this a little bit later when I get into some of the regulatory stuff. So I will come back to that in a few moments, or a little bit later on. So again, you don't always have to stop at the bottom rung of the ladder is basically what I'm getting at. You can start higher up if you suspect they're really having very severe pain, especially if it's something to where they come in and they broke their arm and it looks like a gooseneck, right? Like, yeah, that person needs pain management and he probably needs some opioids right now. So the most severe pain, you can start at the top of the ladder and then work your way down as their pain starts to get a little bit better and the acute situation has kind of resolved itself to some degree. So keep in mind, inflammation is going to be a huge component of what these patients are experiencing here, right? Whether it be trauma, some sort of chemical irritant, could be infection, whatever the case may be. The inflammatory cascade that happens here is going to be identical amongst all of these, right? You're going to be developing histamine, prostaglandins, leukotrienes, all these different things here. You're going to get swelling, you're going to get redness, you're going to get all of that you're normally associating with inflammation, which we've seen and talked about previously. And so not only that, but the body is doing damage to itself, right? So you have things like the leukocytes that are releasing those lysozymes, causing tissue damage. But also, too, think about the pain fibers that are, say you stub your toe and your toe hurts now. All those pain fibers get sensitized to that through things like prostaglandins, substance P, and whatnot. And that will make those fibers more likely to send those painful signals up into the brain to say, hey, this hurts, right? So if we can do things to try to limit that inflammation and limit that sensitivity of those pain fibers, you get fewer signals being sent and thus you experience less pain, right? We'll talk about the neuronal pathway here in just a moment. If you imagine you have some sort of tissue injury here, imagine someone cut their finger or something like that. You see the tissue damage, see this big crater here, and then you see all the substances being released here, substance P, prostaglandin, serotonin, all that kind of stuff. And these nerves are getting sensitized here, and so they send these signals up through the spinal column, which we're going to see. This is going to be an important feature of the pain pathway we'll talk about. And so you see these signals being sent up through the spinal column, up into the brain, and then out into the limbic system to say, ow, this really hurts. We should probably do something about this, right? Whether it's remove your hand from the thing that you just cut yourself with or whatever the case may be. But those pain signals are going to be that's important survival mechanism to say, hey, stop doing what you're doing, get away from that thing because it really hurt, right? So we're going to find, starting off with anti-inflammatories, that by inhibiting prostaglandin and leukotriene synthesis, you're going to be able to block a lot of that vasomotor activity. You're going to be able to decrease the amount of inflammation experience because less leukocytes are coming in and they're releasing less of those lysozymes from being released. And so overall, pain and inflammation should go down, okay? As I mentioned, prostaglandin sensitize pain fibers. Well, do we have anything that decreases prostaglandin synthesis? Sure we do. Remember we talked about our NSAIDs last semester when talking about things like dealing with fever, for instance. Now we're going to focus on the analgesic activity of the NSAIDs that we deal with. And so pain like this is typically more on the mild to moderate side of things. And so this is where using anti-inflammatory drugs like NSAIDs are going to be sort of the bread and butter of their use here, right? So as you remember, cyclooxygenase is the main enzyme responsible for producing those prostaglandins, right? We talked about irreversible versus reversible inhibitors. Remember aspirin being the main irreversible inhibitor of that. We don't necessarily need that because if this is an acute pain thing, I don't need an irreversible inhibition of COX. So we can focus on the reversible ones. And we'll see in some cases they may work a little faster or slower depending if they're competitive or not. I don't really care to know that. But if you recall, we talked about there's two different isoenzymes of cyclooxygenase. There's COX-1 and COX-2. COX-1 is that constitutive enzyme that is always in function, that is actually working on the stomach to cause that protective barrier to form. Remember, if you get rid of that through chronic NSAID use, you can get peptic ulcers. Whereas with COX-2, that's the inducible one. If you stub your toe and cause inflammation to occur, COX-2 is being upregulated. And so when dealing from a pain standpoint, COX-2 is a more important one to deal with, okay? So you're saying, well, why don't we just block that one and not COX-1? I'll tell you why in a few moments, and it actually is pretty important. So we'll get into the medications in just a few moments here, but mainly what you're going to see is that in general, for somatic and visceral pain, for more mild to moderate cases, NSAIDs and acetaminophen are going to be your bread and butter, right? And or corticosteroids, which may be used occasionally, but again, be sparing with this because if you recall, corticosteroids have a whole host of side effects we don't want to deal with. And then plus or minus opioids, right? So again, if they are experiencing a femur sticking out of their leg and I give them acetaminophen, they're going to be pretty mad at me. I should probably just go straight to the opioids, okay? Versus they come in, they stub their toe, I can probably get away with NSAIDs or acetaminophen, right? On the other hand, neuropathic pain, you're going to see that the treatment is going to be far different because of the fact that it's not necessarily inflammation that's happening here. It's the nerves themselves that are being damaged and causing these painful signals to be sent. And so we're going to require different medications here. So we'll get into some of these briefly here. We'll talk more about these a lot when we get into the behavioral health section and also the neurology section later on. And then some of these patients may still require opioids, but ideally, for all these cases here, if we could use as few opioids as possible, that's going to be a good thing. Opioids are very good at what they do, but again, if we can limit how often we're using them, that's going to be beneficial for the patient, right? Okay, so remember, when we're dealing with these patients, we should include both pharmacologic and non-pharmacologic modalities. So making sure we're utilizing things like PT where appropriate, making sure we're looking at things like, taking care of their, psychosocial issues as well. And when we're treating this, again, the goals may be different from patient to patient. Obviously, you would think that the goal is to eliminate all pain, but realistically, that may not be possible depending on the patient or what they're experiencing. And so it's important to consider, well, if I can get this patient who experiences an 8 out of 10 pain all day long every day, and I can get them down to a 4, that's a big improvement for them, right? They're going to feel a lot better. They may be able to gain functional capabilities back that they have lost recently. That's going to be a good thing. Getting them down to 0 just may not be in the cards for that patient, which is unfortunate, but is, a reality we have to deal with. But overall, and this is the important thing, is to not get tied to that number. It's very easy for people to get tied to their own number and for you just to look at that because it's easy to document. You can just say, okay, they had a 6 out of 10 pain. It's easy, you're done. What you want to do is to be able to look at all the other stuff going on with the patient to say, okay, well, how's their quality of life? Are they enjoying life at all? Are they like super depressed because they're having this pain? What is their functional capacity? Are they able to get up and go around and do the things they want to do? Can they go and pick up their grandkids? Can they go to work? And ideally, when you have people getting adequately managed from their pain, they should gain functionality, right? Should gain independence or regain the ability to do things they couldn't do before. What you'll find is when we talk about addiction is that's going to be a very different case there. The typical when patients are getting, having their addictions being sort of fed a little bit, you're going to see they actually lose independence. They lose some of their functional capability, as we'll see in a little bit, okay? Anyway, so treatment's individualized, needs to be based on the type, severity, patient history, all the stuff we talked about recently. And you may find that there could be patients that respond differently to these medications here. For some people, they respond really well to opioids. Other people may not. And some of that goes back to the pharmacogenetics of those patients there, right? And so if someone tells you, oh, Dilaudid works better for me than this other drug, that could be a sign of pain med-seeking behavior, or it could be the actual truth, right? And so that's where looking at the history is important to see what they've gotten in the past. But for chronic pain especially, it's common to require multiple agents, right? So we'll look at some of those options there. Typically, if one therapy fails, it's usually due to side effects or inadequate efficacy, not adequately treating their pain. And so then at that point, we should try some other modalities. Okay, so here's kind of the layout of the different medications we're going to talk about. We'll touch on acetaminophen, the NSAIDs. We'll get into our opioids and then talk about some adjuvant drugs, which we can add on to try and help manage these patients' pain. So acetaminophen, we talked about this before. We talked about it as being a antipyretic, so it treats fever. Notice though it's not an anti-inflammatory. So whereas NSAIDs are antipyretic, analgesic, anti-inflammatory, acetaminophen does not do anything for inflammation. It just treats fever and pain, okay? So if someone who's having a really strong inflammatory reaction like rheumatoid arthritis, acetaminophen is not going to do a whole lot for them, right? And again, we don't know the full mechanism for how it works, but we do know that it's better for mild to moderate pain. We know that it's good for things like osteoarthritis, minor aches and pains, things like that. And we like it because it's generally pretty well tolerated for the most part, right? We'll talk about some of the caveats with that. But for most people, for mild to moderate pain, it's going to be pretty good for them, right? You may find it has limited usefulness in severe pain, but there is something we call opioid sparing effects. And so this is a really important thing, especially if you work in surgery. You'll deal with this, where we try to give other medications to try to limit how many opioids we need to use. We'll talk about what the benefits of that is when we look at the side effects for opioids a little bit later on, right? I'm sure some of you may want to go into surgery, so I'll try to put in perspective of that. But we even have IV forms available as one called Ofirmiv, and it's kind of nice because we use this a lot for patients who, one, can't take oral acetaminophen or rectal acetaminophen, or in a lot of cases we use this in conjunction with while they're undergoing surgery, because we find overall that it reduces the number of opioids that they require. So that's kind of the other benefit of the acetaminophen. So for severe pain, you can add it on, it may be able to help a little bit, but it doesn't necessarily treat the pain by itself. So it's a good adjuvant for severe pain, but it could be used as monotherapy for mild to moderate. So basically, we think it's kind of working more centrally in the CNS for all those pain signals that are coming in to help kind of limit that. But for the most part, it does not work in the inflamed tissues. It just gets deactivated there, right? The benefits for acetaminophen include that it doesn't have any anticoagulant effects. So there's no bleeding risk associated with this necessarily. There's no GI effects, so it's relatively safe for patients to take this chronically. There's also no respiratory depressant effects, no cardiovascular effects, so very safe from that standpoint, right? The issue, which I'm sure most of you are aware of, is the hepatic problems you run into for overuse of the medication. So in general, you don't want patients to go above 4 grams a day, and even in that case, that might be too much for some people. You may find that you find lower recommendations, like say 3250, I think, is the milligrams is the recommended in some cases, especially if they have a history of hepatic impairment. Definitely reduce the amount they're going to be getting, okay? Because overall, you're going to find that too much acetaminophen is going to cause liver damage over the long term, and you have to consider all sources for acetaminophen. And unfortunately, acetaminophen is really easy to get access to. I can go to Costco and get a 55-gallon drum of this stuff for like $10, right? So most people have it in their homes, and most people may not realize when they're getting other medications that include acetaminophen, right? So imagine if someone was getting hydrocodone and acetaminophen, which is a common combination of opioid plus Tylenol, 5-325. So they're getting 325 milligrams of acetaminophen. They're taking it every 4 hours, so 6 times a day. And then they're getting, say they're using their OTC Tylenol, they're taking 650 4 times a day. That's going to be well above the 4 grams, and if they're doing that every day for a couple of weeks, they can definitely cause some hepatic injury, right? Which could be severe enough they need to be admitted and given the antidote, and potentially even need liver transplant in some rare cases. But you don't want that to happen. So the big thing is when you're prescribing medications that include acetaminophen, you have to tell the patients, remember, do not take anything else that includes Tylenol, because of the fact that it's going to interact with this and be too much for you, okay? And nowadays you see a lot of warnings on everything that includes Tylenol. It says a warning, this includes acetaminophen. So there's plenty of warnings out there because we realize that this is an issue. It's happened to a lot of people, so make sure you're not going to be the ones doing that to your patients, right? Education is key. Up next, we have the NSAIDs. Remember, we've talked about these before. The good as an antipyretic, good as anti-inflammatory, but also pretty good as an analgesic there. Now, most of the ones we deal with, whether OTC or prescription, is going to be non-selective, meaning they inhibit both COX-1 and COX-2 enzymes. That's why you see patients who are chronically treating themselves with NSAIDs, like ibuprofen, for instance, can cause peptic ulcers to occur because they will inhibit that COX-1. That protective barrier in the stomach is going to be diminished, and they can cause the stomach acids to start eating through that tissue, causing ulcers, perforation, all kinds of bad stuff, right? COX-2 is what we're really focusing on, but we're going to see there's some issues if you have drugs that only affect COX-2, okay? That's going to be some of the caveats we're going to look at. And again, you can see the mechanism here for how this works by blocking this, especially the inducible type, the COX-2 isoenzyme. By blocking that, you're going to reduce the production of a lot of these inflammatory cytokines. Overall, pain's going to go down, inflammation is going to go down. Those pain fibers are not going to be as sensitive anymore, so those signals, not as many, get up into the CNS to say, hey, you're having pain right now, right? So main ones we're going to deal with include aspirin, which most of you are familiar with, but this is typically relegated more so to, cardioprotection. Some people still use it. They'll use their BC powders, their Goody powders, things like that. If you're from the north, I tend to find that not a lot of people have heard of these before, but if you're from the south, it tends to be more of a common institution. But Goody's powders, BC powders are basically powdered aspirin put in these little wax paper sachets that you can dip into your drink and then take that. Some people don't even realize that a Goody's powder is aspirin. I've had cases of aspirin toxicity because people were taking aspirin on top of using the goodies powders, not realizing it's the same thing, right? So again, education is key. Common ones you're going to run into from a pain management standpoint include the over-the-counter varieties like ibuprofen and naproxen. Remember, the big difference here between aspirin and these other NSAIDs is that aspirin is irreversible on cyclooxygenase. So remember that, for the life of that enzyme is going to be inhibited. So bleeding risk is going to be higher with aspirin versus, or at least longer acting. The bleeding risk is longer lasting even when the aspirin's out of the system. Whereas with these other ones, they're going to be reversible. As soon as they're out of the system, bleeding risk goes down. Okay. But common over-the-counter varieties, naproxen, ibuprofen. And then some of the common ones you'll see used from a prescription standpoint for pain management includes like indomethacin, Tolmetin, and ketorolac or Toradol. If any of you have heard of Toradol before. Toradol is like a really good like workhorse IV NSAID that's available. So if you go into like an ER, for instance, you're complaining of like kind of moderate pain, probably not enough pain to require an opioid, but more so than simple oral ibuprofen or Tylenol can handle, then they'll probably give you Toradol. That's just a really good IV NSAID that we have available to us. There's not any one advantage to one over the other. They all work pretty similarly to one another, but the dosage forms can matter. So if you need an IV NSAID, you're probably going to go Toradol 10 times out of 10 for the most part. Even though we have IV ibuprofen available to us, we just don't use it too often because it's generally more expensive than Toradol is. And then you'll find that different patients may respond differently depending on their pharmacogenetics, but typically you give them 2 or 3 weeks to see how it's going to work for them, and then you go on from there. Now, in terms of side effects, remember all of this is stemming from the COX inhibition, right? So gastric and intestinal ulceration, again, due to that decreased protective barrier, it's a chronic problem, right? And in fact, when you look at something like Toradol IV in the hospital, if any of you have seen this, you'll probably notice that it's limited to 5 days of therapy. You cannot go beyond 5 days of Toradol. The reason why is because the risk of causing gastrointestinal issues is so high that it's just not worth it at that point. You need to switch over to something else. And so you'll find automatic stop dates usually put in for Toradol orders that providers are not able to override because we know the risk is so high. We know the bleeding risk due to inhibiting cyclooxygenase in the platelets. And then there could be some hypersensitivity risk. Some people, it just depends on if they're sensitive to that or not. And then you do want to be careful for patients who are pregnant. We will talk about pregnancy and medication use later on in the OB-GYN section at the end of the course. But there could be issues where you can have delayed spontaneous labor. And also you don't want to use NSAIDs towards the end of pregnancy because it can have some fetal effects, including closing the ductus arteriosus too early. Not sure if you guys have gotten into fetal heart flow or blood flow yet, but that's an important duct to keep open while the patient is not breathing and not outside of the mom yet. Okay. Some patients with asthma may actually experience bronchospasm due to NSAID use. Basically, if you imagine going back to that slide here where we talked about the mechanism, if you block this enzyme here, that arachidonic acid is still being produced, and they all get shunted over to lipoxygenase. And we talked about leukotrienes and their role in asthma. So some patients may be sensitive to that. So if you ever hear someone saying, I have an ibuprofen allergy, or I have an aspirin allergy, I had an asthma attack with it, that's what's happening there. And so that's a legitimate hypersensitivity you would not want to try and induce again for those patients. That's a legit one there. Some patients, you do want to watch their hepatic function. This is not as severe of an issue as you would see with the acetaminophen, or at least chronic use of Tylenol. So at least watch out for that. And then again, remember the renal function issues. If you have an older patient who requires those prostaglandins to keep that afferent arteriole open, and you give them an NSAID that's going to close that afferent arteriole down, and it's going to decrease their GFR. So it's very easy, if you're not careful, to have patients with moderate, to severe renal dysfunction, give them an NSAID, and then their renal function tanks even further, right? For most younger patients, it's not going to be a problem because they don't require this prostaglandins as strongly, but just know that, right? So be careful in older patients, giving them an NSAID can reduce renal function acutely. Okay. So as I mentioned, aspirin is going to be irreversible. That's the big difference here with these versus the others. Even if aspirin is out of the system, note that it's still going to have those bleeding effects long term, right? Until you can replace that those platelets there. Okay, and again, it's non-selective. It'll affect COX-1 and COX-2 just the same. It does not have a preference for one over the other. For pain management purposes, you will probably not use this too often because of that increase in bleeding risk, right? Remember, for most patients for cardioprotection, they're taking 81 milligrams a day. For pain management purposes, you need to be giving like 325 to 650 milligrams. You're giving much bigger doses, so the bleeding risk also goes up as the dose increases. So just be aware of that. And again, be really careful with salicylates anyway, because they have a lot worse toxicity profile than you would see with an NSAID, right? If I had two patients that were identical, they're identical twins, one had overdosed on ibuprofen and one had overdosed on aspirin, I am much more worried about the aspirin patient. It is much more toxic, which is why most people shy away from it unless they're using it for those cardiac protective purposes, right? But remember, if you have anyone who is experiencing or taking salicylates and they're experiencing tinnitus, that's a common side effect. It's a good sign they got too much aspirin on board, okay? And it's easy for patients who are self-treating their pain to overdo it with the aspirin and cause that. I recall one time during my fellowship, part of my training, my staffing responsibilities was working in the poison center, and I'd actually take calls, from people from home saying their kids got into something, all the way to physicians calling from hospitals asking for a consult. And I remember this one young lady called up, and she had tried to harm herself, and she was calling up because she got scared, and basically said she'd taken a bunch of aspirin. And so I was trying to get some bits of history from her, and she kept going, "What? Speak up. What? I can't." She couldn't hear me because of the tinnitus she was experiencing due to the aspirin, right? And that was a big sign to me of like, okay, this girl's already got a whole bunch on board. We need to do something about this right now. And so we were able to get EMS over and help her out. But just be aware of that. Again, side effect profile wise, aspirin is going to not be preferred as compared to a lot of the other NSAIDs. Okay. Again, in terms of contraindications, be aware of bleeding disorders. Also be aware of the Rey syndrome risk. This is also unique to salicylates. So overall, for pain management, don't even worry about aspirin, or try to avoid your patients from using aspirin other than very occasional random intermittent use. But you'll find some older patients use it all the time. Now, we've talked about Rey syndrome before, so I'm not going to belabor this point here, but just remember it's for kids, usually less than 16 years of age, post-viral typically when maybe they have a fever, and it causes this kind of progressive encephalopathy that early on may look like the illness they experienced, and then it gets worse and worse and worse, and if you don't catch it early enough, it can be quite fatal. So definitely be cautious with that, and I just would avoid aspirin in those kids regardless, right? There's still some cases we use it. For instance, for like Kawasaki's disease, aspirin is kind of a go-to treatment, but again, it's very specifically in these post-viral sort of situations. Okay, so next we want to talk about some of the other NSAIDs we have here. These are what we call the propionic acid derivatives. Basically, you're going to find that these will have pretty good therapeutic actions here. They don't have as much of a bleeding risk here. They also have less renal and hepatic toxicity. And they can be used for all kinds of things like arthritis, muscle pain, dysmenorrhea, all kinds of mild to moderate pain issues. These drugs can work pretty well for these patients. And you'll see here we have a lot of different options that are available to us. We have things like ibuprofen, naproxen, which most people are familiar with because these are the ones that you can get over the counter. But other ones we have here, things include ketoprofen, phenoprofen, flurbiprofen, kind of fun to say, and then oxaprosin. Big differences here you're going to find mainly is going to be in things like the half-life of the drug. Now, am I going to ask you on a test which one has a 14-hour half-life versus a 2-hour half-life? Probably not. But just to give you an idea of why you might want one that's longer lasting than the others, well, it could be for someone who has chronic pain issues, right? If I take ibuprofen for a headache, that makes sense because once that headache is gone, I don't need the effects of the ibuprofen run anymore. On the other hand, though, if I have chronic pain that I'm experiencing pain all day long for months and months and months, something like oxaprosin may be good because I may only have to take 1 dose a day versus 4 doses a day of ibuprofen, for instance, right? So it helps out with the compliance from a big standpoint, right? So better compliance if you have more simple regimen. So, a lot of questions here. That's good. All right, someone was saying, what's the purpose of for salicylates and Pepto-Bismol? Pepto-Bismol is bismuth subsalicylate. The benefits there, it may cause like maybe in some cases, if you have, for instance, like H. pylori, like you'll find a lot of those regimens will include Pepto in that. Basically, it can help out with some anti-inflammatory actions, but it doesn't help out necessarily with any, if you're having like acute, gastroenteritis or something, it's not going to help out with that necessarily, but it's just, that's the compound. That's just what we have there. So maybe some benefits in rare cases, but otherwise, just kind of there. I don't know the full genesis for the making of Pepto-Bismol, how that came about. Someone says, since aspirin has a bleeding risk, is it not advised to take aspirin for menstrual cramps? I don't know necessarily that you're going to see increased bleeding as a result of taking aspirin for like menstrual cramps, because again, if you think about why patients are having bleeding during menstruation, it's because all that uterine tissue, they're basically sloughing off. So it's not like they're having like active bleeding, it's just a matter of all that tissue is just kind of being sloughed off in order to be eliminated for the next ovulation cycle and the next menstrual cycle. So I don't know necessarily that I would say it's contraindicated. I probably wouldn't recommend it, mainly because the NSAIDs overall have a better side effect profile than aspirin. So I'd probably would recommend that over aspirin, probably for really anything. To be honest, but some older patients, that's just what they grew up on. They've been taking it for decades, and so it's hard to get them to switch. I don't know that a lot of patients nowadays are going to necessarily jump to taking aspirin, so I probably would just go with an NSAID. That's much more reasonable, and again, bleeding risk is lowest with those as compared to aspirin for sure. Okay, someone said clarification: NSAIDs inhibit both COX-1 and COX-2. This is why they have the GI effects. Correct. Remember that because they're non-selective, they'll affect COX-1. COX-1 is why we get that protective barrier. It's the forming of those prostaglandins, because that's the constitutive form of that enzyme, right? Okay. Someone said, are there any propionic acid derivatives that are OTC besides ibuprofen and naproxen? If there are, I'm not familiar. I think ketotifen was for a period of time, but I think that might have been removed, or at least it has a different dosage form. So I'm only familiar with these two being over the counter. The other two, or the other ones, would be prescription only for the most part. Good question. Thank you for asking. I really appreciate that. A couple other ones you have here include things like indomethacin. This one tends to be fairly okay in terms of use. I see it used chronically occasionally. But again, if you are thinking about giving your patient an NSAID or recommending an NSAID, oftentimes it makes more economical sense to try something like ibuprofen or naproxen first. But if they're having more chronic issues, you want something with longer term effects, something like the oxyprosin, that's when you want to start thinking about prescriptions for these drugs, because it's relatively cheap to get ibuprofen versus having to get a script done, depending on the insurance coverage and things like that. Indomethacin is really kind of interesting because we use this for a long time IV to actually close the ductus arteriosus. And you saw that was a problem before when patients were pregnant. You don't want to close it when the baby is still in the womb because they require that ductus arteriosus to be open. Sometimes when they're born, you'll find that it closes or it doesn't close when it should, and that can cause some blood flow issues. And so we can actually give an NSAID after they're born to close that ductus arteriosus. So if you ever see an IV indomethacin or IV ibuprofen, chances are it's being used to do that from a chemical standpoint. Sometimes you have to go and do a surgical ligation, but we try the chemical first most of the time. Again, you're going to find the side effect profile tends to be a little bit higher for indomethacin than some of the other ones, like the propionic acid derivatives. We like to prefer short-term use mainly due to the gastrointestinal effects. So big thing you want to see with that. And remember, because of the effects on the kidneys, you're going to get reduced effects of diuretics, okay? Because, again, less blood flow is getting to the kidneys, or getting into those to the glomerulus, so it makes sense that your diuretics would be less effective. Okay. Let's see, someone else had a question here. It said, can someone be allergic to only propionic acid derivatives, or would they be allergic to all NSAIDs? That's a good question. If someone had an allergy to ibuprofen, first I would kind of inquire about what the allergy was. If it was something like they had an asthma attack, then that might be NSAID wide, right? So because anytime you inhibit that cyclooxygenase, it could shunt it back over that arachidonic acid to produce leukotrienes and cause an asthma attack. That's probably going to be every NSAID. If it was like a true blue, like anaphylaxis or anaphylactoid reaction they're having, then utilizing something not a propionic acid derivative may be reasonable, right? So it's a good thing to ask, okay, what have you taken before? What have you had issues with? What have you not had issue with? And that may give you a clue, right? So someone who had ibuprofen, who had anaphylaxis, they may be able to receive Toradol, and that might be okay, right? So I would not say it's class-wide unless it's more the asthma exacerbation we talked about earlier. Okay, so Toradol, ketorolac, ketorolac, some people say is a proper pronunciation, but you sound kind of nerdy if you say that, so I always say that, but Toradol works for most people. This one is like the go-to IV NSAID, especially for acute pain. Some people even equate this in terms of efficacy for analgesia, kind of like a weak opioid. So it works really, really good, and it's opioid sparing. That way you don't have to give as many opioids because this is doing such a good job inhibiting that pain, right? Not as good as an anti-inflammatory, but really good as in terms of an analgesic. So this is why it's such a workhorse in the ER. If you ever go and work there, you'll see that all the time. And this is why we limit it to 5 days of use, is because of the GI effects. And it's got its own black box warning just because of that. So be very careful from that standpoint. Could have bleeding risk, so watch out for that. And again, no more than 5 days. Another example would be piroxicam. This is a good kind of not over the counter, it's a good prescription outpatient sort of NSAID you may see used for these patients here. Fewer GI effects, that can be kind of beneficial there, as opposed to maybe some of the other ones like indomethacin, for instance, is going to have higher. So again, you'll find as you practice, some of these drugs may be better for certain patients, especially if they have a history of GI illness in the past. Like this may be a reason to use something like piroxicam as opposed to something like indomethacin, for instance. Now, meloxicam, this is interesting. So now we're starting to get into the idea of selective NSAIDs here. Grace is saying, does the 5-day limit to Toradol apply to eye drops as well? I would have to check that out. Let's look that up real quick. Let us see. I'm going to do this live time with you just to show you that I don't know everything. And it's important to look stuff up. Make sure when you're looking this stuff up that you want to make sure you're using the appropriate dosage form. So you can see the ophthalmic here. I think there is a duration of use limitation on here. Let's see. No, it doesn't appear to be so. Yeah, so it looks like, because there shouldn't be any gastrointestinal effects from Toradol on the eyes. There shouldn't be enough systemic absorption for that to be an issue. Yeah, it's being used for much longer. Yeah, so it does not appear to be a problem. They can keep using it indefinitely. It's just for the IV formulation. You'll see oral occasionally, but it's not real common. That's why in the hospital you see like IV for 5 days, and that's usually most frequent. You'll see that. Anyway, so yep, no problem. So getting into meloxicam, this is interesting because now we're starting to get into selectivity. So like we mentioned, okay, well, COX-1 is used for all that GI stuff, so why don't we just inhibit COX-2 by itself? And so now we're starting to get into that a little bit. And so there's idea of selectivity for one isoenzyme versus another. Just like you can have drugs that are, selective for one receptor or another, just like you can have H1 blockers and H2 blockers, for instance. Here's a case here where now we have a drug that has 10-fold selectivity for COX-2. It still inhibits COX-1 a little bit, but it's going to be more preferential for COX-2. So what does that do for us? Well, you're going to see there's a little less GI toxicity associated with this than our non-selective agents. So if I had a person who had a history of peptic ulcer disease due to NSAIDs, this might be a more reasonable drug to use for them, right? Because it has a more selectivity for COX-1. It kind of leaves, it has more selectivity for COX-2. It leaves COX-1 alone to some degree, right? Still affected a little bit, but not as much, okay? And so again, it can be difficult for students sometimes to try to get sort of the shades of gray here, because you want to think it's either an all or none sort of phenomenon. But selectivity is going to be relative, right? It's always relative to the absolute of picking one just versus the other. So there's going to be some selectivity here, but it's not total. Another one here called diclofenac or Voltaren. This one's pretty neat because we actually have topical formulations, which I believe is over the counter now. That was a recent development in the past couple of years. But if you ever see Voltaren gel, that's nice because if you can use it topically, it only works where you put it. So if I had someone who just had like knee osteoarthritis, like maybe as a former athlete or runner or something, and they just had their knees that were being affected, it's better to go ahead and just use a topical formulation as opposed to affecting their entire body, where the pain's only working in their knee, then just put it on the knee, right? Systemically, it also has some COX-2 selectivity, but systemically has a little bit worse side effect profile here. Some GI problems like the bleeding and ulcerations and all of that. So not ideal from a systemic standpoint, but the topical formulation is kind of what sets this one apart. Okay, so we talked about a few that were somewhat COX-2 selective. For a short period of time, we had drugs that were completely COX-2 selective, right? Oh, good. Yeah, the Family Med PA you were shadowing was very fond of it. Yes, I think it's a good go-to for like just like limited areas of pain. If it's more like systemic, or if it's like a large area, you may consider more systemic use. But I think it's a good way to start at the very least, right? Now, if you're looking at like compliance from a patient acceptance standpoint, obviously using a tablet or something like that is much easier. You can just pop a tablet and you're done, versus like having to apply a topical product, which can like stay in your clothes and stuff like that. So I think from a provider standpoint, you're like, yeah, that works great because it just goes locally, but it may not be acceptable to the patient. So again, it's maybe sometimes you have to do a little bit of finagling, a little bit of trying to think of the word. Trying to kind of bargain with them a little bit, be like, hey, just try this out, see if it works. Maybe it'll be perfect for you. You never know, right? Convince them. Convince is a word I could not think of there, right? Anyway, so you're thinking, well, why don't we just use COX-2 selective drugs? Like, why don't we do that? It would eliminate all those risks for the GI effects. It wouldn't have any more peptic ulcer disease. Everything would be great. Well, we tried that and actually did not go so well. There was 2 drugs. If you ever heard of the drug Vioxx, and Vioxx was kind of an old bit of news by the time I was in school, which is like 10 years ago, which is very sad for me. But so if you've never heard of it, you can look it up. It's kind of an interesting story. But basically, we put out a couple of drugs on the market. Rofecoxib or Vioxx was really the big one. And this was like blockbuster news. This is like huge for all these patients that had pain, but they couldn't take NSAIDs because of stomach issues. They were like, yeah, let's do this Vioxx. This is perfect for us. However, when you do clinical studies, remember you're not testing millions of people, so you can't find 1 in a million side effects without some extraordinary luck. So once this got out into the market and it was like huge news, it got out, everyone was using it. They realized there was actually an increased risk of heart attack and stroke. Turns out when you only block COX-2 without blocking COX-1, you can cause some issues there. And mainly the issue is that with COX-2, you need a little bit of a balance there because you have issues of things like angiogenesis being inhibited. And so if you can't produce new blood vessels, that becomes a bit of a problem in supplying blood flow to places like the heart and the brain. So that's why we actually saw for patients who are just having pure COX-2 inhibition, they had an increased risk for heart attack and stroke. That ended up getting it removed from the market. And so we are left with drugs that may be somewhat selective for COX-2, but are not totally selective because that kills people. So basically what we're going to see here is we have one agent left here. Totulite you might see occasionally, but celecoxib is the one I want you to know because of the fact that this one is used most commonly. Basically, Celebrex or celecoxib is going to be relatively selective for COX-2, but it still has a little bit of COX-1 activity. If you're looking on the scheme of things, like if ibuprofen is totally non-selective, you have like something like meloxicam kind of being like in the middle a little bit, and then celecoxib being kind of on the other far side in terms of selectivity. So this one being as about as selective as you can get without causing any issues in terms of like heart attack and stroke and killing people, right? So the data we have, at least, it looks like celecoxib is probably pretty safe for the most part, but it helps to limit the GI side effects. That's the benefit. So if you had a person with a history of peptic ulcer disease and they needed to go on an NSAID, if you still wanted them to be on an NSAID, then Celebrex might be a really good option for them, okay? So again, looking at this, we see that the ones that were most selective got taken off the market because it was just too big of an imbalance there. And again, it has to do with this issue of inhibiting prostacyclin production more so than thromboxane A2. So what this led is that overall you end up having issues of these epithelial cells of the blood vessels not being able to develop appropriately. It also increased blood pressure, led to kidney function issues. So a lot of big problems there. So that's why Celebrex is about as selective as we're ever going to get, because otherwise it's going to cause increased risk for death for these patients here. Okay. So any questions on the the NSAIDs so far? Let's see. Someone said, are the COX-2 selective agents RX only? Yes. So really, the big options you have available too in terms of over-the-counter NSAIDs are going to be orally, ibuprofen and naproxen, and then from a topical standpoint, the diclofenac or Voltaren, right? I remember back in the day when I first got married, we had to go to, we went on our honeymoon we did a couple of day cruise and went to the Bahamas, and we thought it was awesome because we can get over-the-counter Voltaren gel, so we ended up stocking up, and nowadays you can just get it here in the good old US of A, so how about that? Things change all the time. The only thing that stays the same is change. How about that? Okay, so let's get into our opioids. This is big topics. I don't know if I'll be able to cover all of it here in the time that we have, but we shall see. So opioids, where do they come from? If anyone's not familiar with this interesting looking plant it is the poppy plant. And basically when I say opioid, it's referring to anything that is activating the mu, kappa, or delta opioid receptors, okay? The mu receptor is the thing we're going to be focusing on primarily for our purposes. However, be aware that there are some activities in kappa and delta that do some various activities, but we're going to kind of gloss over that for now. You may see OP1, 2, and 3 as the newer nomenclature. OP1 is the mu, OP2 is kappa, etc. And these are going to be useful for more moderate to severe pain. Okay, so if Tylenol is not cutting it, if NSAIDs are not cutting it, is where you bump up to the opioids, right? So how do these work? Well, they don't really do anything. Like the NSAIDs would work at the site of pain because they help out with inflammation, but the opioids are going to work both in the spinal column itself to inhibit pain signals, and that is the Greek letter for mu, if you're not familiar. And it also works up centrally up here in the brain itself to inhibit those pain signals from coming in. So, and I've never taken an opioid. Actually, I think I did when my wisdom teeth were taken out, but it was a really wimpy opioid. But I recall one of my teachers in school talking about it, and he said it was after surgery, and he had taken some, he's been given some opioids by his provider, and he said he knew he was in pain, but he didn't really care so much about it. So I thought it was a good descriptor for how that is. It doesn't get rid of the pain completely; it just blunts the signals and kind of keeps so many of them from getting up into the CNS, where you kind of have that sensation of, yes, I'm having pain. Somebody said is indomethacin contraindicated in pregnancy? You tend to find that we'll talk about pregnancy categories later on in the OB-GYN section. So if you look at pregnancy categories, there's A, B, C, D, and X. A and B are safe for pregnant patients. C is kind of like we don't really know. And then D and X are dangerous. You tend to find that towards the end of pregnancy is where you want to avoid all NSAIDs, because all of them could cause that closure of the ductus arteriosus. So they actually become a D category towards the end of pregnancy. I'm probably not going to focus too much on the pregnancy stuff until we actually get into it towards the OB-GYN section. So I just kind of put that up there just kind of for your info there. Okay. That's basically how the opioids are going to be working here. So, and more specifically, you can see here how the mu is going to be affecting the neurons in that dorsal spinal cord. You're going to also find those receptors in the brain. And the important thing here is it's responsible for both the analgesia, which is what we want, but also causes the respiratory depression, which is what can kill these patients, and then also the euphoria that patients are looking for when they're abusing it to get high, basically. You'll see the kappa and the delta can have different effects here, including things like dysphoria and things like that, but we're not going to focus on those because these are relatively minor players and when we're talking about pain management purposes. We're going to just gloss over that. I'm going to hope my wife doesn't hear me say that, because she'll say, those are important receptors. And I'll say, not for our purposes here today. We don't need it. Anyway, so some different things we're going to get into when we talk about the actions of these opioids here is that certainly all of these are going to be at least somewhat of an agonist for the mu receptor. That makes sense, but we're going to find that we also may have some drugs that are just a partial agonist. To get even more complicated, some of them may be an agonist at one type of opioid receptor and an antagonist at others. This is rare. We're not going to focus too much on this, but what's really important to know about is the antagonist, because what if someone takes too much of an opioid? We need some way to be able to reverse that. Okay, so that's going to be important. Some of you probably already know what I'm talking about there, but we'll get into it in just a little bit. Agonists are going to be the most commonly used ones, as we'll see here going forward. So let's talk about addiction and chemical dependency. It's really important to understand the difference. And again, I know that when I was in school, I was a young lad and did not understand really the differences between these terminology. I just thought addicted was addicted, right? Not the case, though. Okay, so there's a couple of different things here in terms of terminology. Physical dependence, and I think I go over these individually. Yeah. So what is physical dependence, right? This is a normal phenomenon that occurs with a lot of drugs. It's not just with opioids. It can happen with our benzos that we'll talk about in the neurology section. It happens with alcohol. It happens with corticosteroids. It happens with a lot of things, right? It has to do with the fact that your body gets used to the situation that it's in. It's just a part of homeostasis, right? So anyone who's on opioids for a decent period of time, so say weeks to months, their body gets used to that. That's the new normal that they're experiencing, having increased mu opioid receptor activity, right? Now, again, you think about what normally activate those receptors. Normally things like dynorphins and enkephalin stuff. So if you ever hear about a runner's high, that's when those opioid receptors are getting activated from naturally occurring opioid substances in our brain. But when we're supplementing that with exogenous opioids, what we're going to see is that the body gets used to that. So if you stop its use abruptly, you can develop a withdrawal syndrome, right? Just because someone is having withdrawal from an opioid does not mean that they are addicted to it. It only means they have physical dependence, which we know is going to happen. That's just natural. No one's is going to be immune from this. what is going to happen when they start to withdraw from that includes things like sweating, the vomiting, nausea, and dysphoria is pretty common. They're going to feel really miserable until they get some sort of replacement for that opioid. Keep in mind, this is not fatal. You will find with certain drugs, withdrawal from them can be fatal. So, for instance, if you have someone who is been abusing alcohol chronically for months to years and they stop abruptly, they can have withdrawal seizures and die from that, right? We'll talk more about that later in neurology, but they'll feel miserable, but no one really dies from an opioid withdrawal, okay? And again, this is a frequent expected occurrence. It is not correlated with addiction necessarily, okay? It's normal process. I'm saying, is the term narcotics synonymous with opioids? I think a lot of people use them interchangeably. I've probably done it a few times already. Narcotics is more of a legal term. It really defines anything that is a controlled substance. So if you look up like the definition here, narcotic. Oops, I don't want Narcotics Anonymous. I just want narcotics definition. So, okay, so let me increase the size of that. The drug or other substance affects mood or behavior consumed for non-medical purposes, especially one sold illegally. So again, this is more of like a legal term. It's usually referred to anything that's a controlled substance typically, or an illegal substance. So like heroin counts as a narcotic, cocaine is a narcotic, things like that. So we'll talk about some of the differences there in the controlled substances in just a little bit. That's where we get it. I wasn't looking up Narcotics Anonymous. That's silly. Why would I ever do that? I'm just kidding. There's no joking matter, okay? Anyway, so physical dependence, totally normal. We expect that, right? Addiction, what is addiction? So this is where they have more of a psychological dependence on the substance here, right? And so kind of the most succinct definition I've heard of addiction is use despite negative consequences. Okay, continued use despite negative consequences. This means that they will have impaired control of the use of the drug. They will have urges that require them to get access to the drug, despite some of the negative things they may need to do, right? So it'll be very compulsive. They're going to have a lot of cravings. Now, someone who's having physical dependence without addiction, they may have those cravings, but they're not going to go and sell off their TV in order to get money to get more of those opioids, right? They won't choose necessarily to, if they have enough money to buy food for their kids versus get a dose of opioids, they won't make that decision to go and, let their kids go hungry. With addiction, you see that because, again, this is a psychological dependence where they will do really negative things. Even though they know they're negative, they know they're bad, they will continue to do them despite the negative consequences in order to get that craving satiated, okay? So that's kind of the big thing with addiction. Not everyone who starts opioids is going to become addicted, right? That should be pretty obvious to most of you by now. But there's a lot of things that could look a lot like addiction to you as a provider that may not really be the case. We'll look at some examples of that and how we can try to identify some of those things there, right? So tolerance is another normal thing we expect to see. The longer you're on opioid for, the more so you're going to get used to the effects of the analgesia and sometimes the side effects, although some side effects never really go away. We'll talk about those later, but constipation is a big one. Most patients on chronic opioids are going to be chronically constipated, right? But not only that, not only do you get do you have adaptation to the analgesic effects of the drugs, but also think about the fact that maybe their disease process has progressed. Think about the fact their pain may have gotten worse. So if they have something like increased activity, maybe they're getting up, walking around, now their pain has gone up as a result. That's a change in pain state. So you may have started them on, say, hydrocodone, or let's say oxycodone, 10 milligrams 3 times a day. Now they're coming back to you and they're saying, yeah, this really isn't working for me. I feel like I need more. You may be thinking, oh, they're just looking for more drugs. Not really. Maybe they're just being more active. Maybe they're getting up, walking around. Maybe their pain has gotten worse and that dose you're giving them previously is no longer sufficient. Okay. This is really difficult to tell the difference, right? Because unfortunately, unless you have some kind of human lie detector, which most people don't have, it can be tough to say, okay, well, is this a true failure of therapy where I need to really increase the dose to overcome tolerance or the pseudo tolerance? Or is this something where they're just looking for more meds? Could this be a sign of substance abuse disorder, right? That's the question. And there could be this, what we call it the pseudo addiction, right? So again, this is oftentimes associated with patients, demonstrating kind of drug-seeking behavior, and oftentimes is due to that under treatment, right? So if that pain progresses, now it's gotten worse, they may have a legitimate need to increase their dose of opioid, right? And so until someone does that, their behavior may not really stop. So once you get their pain control under control, then at that point the behaviors will then go back to normal. So even though they may be seeking drugs, it's because they legitimately have a need for it. And again, this gets very murky. It's very difficult to tell. I'm going to talk about some tactics that we use in order to avoid that. So the question is, okay, well, does this patient have addiction or do they have chemical dependency, right? Or in this case here, addiction or appropriate use, right? Typically, addicted individuals lose function. They can't maintain good relationships with their family or friends. They cannot keep a job potentially. They lose function as a result of their addiction, right? Non-addicted individuals, they will regain function. They'll be able to go back to work. They'll be able to go and play with their kids again. They'll be able to do these things there. So that's some of the big differences you're going to see, and that's why talking to the patients, asking them questions, it's not just about their pain scale. It's about all the other stuff going on with them that these medications may allow them to do, okay? And again, physical dependence is expected. It's a known consequence of long-term opioid use, okay? And again, how often do people get addicted? It really varies, right? It could be, it's very genetic dependent. It's very environment dependent. What are their concomitant disease states? Do they have bipolar disorder? Do they have schizophrenia? All these things can be playing a role. So it's really difficult to tell who's going to get addicted and who isn't. If I could do that, I'd be a billionaire probably, right? So what are some means that we have available to us as practitioners? And again, not all of you will practice in Florida, but I want to make this Florida-centric because that's where we are now, and that's where we're going to do your rotations. But some means to help us determine if patients are having appropriate use of these medications or not. Well, one of the tools that we have is called eForce, right? eForce is basically a database online that you can all sign up for once you have your license. And you can utilize to look up patients to see any controlled substances that they've filled in the state of Florida. And basically every pharmacy in Florida automatically uploads this information such that any healthcare provider can go in and look this up. So pharmacists can do it, NPs, PAs, docs can go and look this stuff up to figure out, okay, well, what has a patient filled? Where have they been filling it, etc. And so I'll give you an example where this really came into play. Normally at a peds hospital, you will find that if an adult patient has a medical issue, we will take them down to the ER, we'll get them stabilized, and we're a peds hospital, we can't take care of adults, and then we'll get them shipped out via EMS to an adult facility, okay? So it's not an uncommon occurrence to see a 40-year-old in the peds ER for some reason, right? Because they're probably visiting a family member or something like that, and they had a medical issue, medical emergency, and now we're stabilizing them, right? So anyways, there's one day I went into work, and I saw one of these patients. There was an older patient who was in one of the rooms. I said, oh, that's interesting. I wonder why they're here. I want to check it out because I saw an order for a dose of Dilaudid. I was like, well, that's odd, that we were giving a dose of Dilaudid to this patient, this adult patient in the peds ER. Let me check it out. Let me see what's going on before I verify the order. That's normally what we do for most medication orders. We check it out and see what's going on with the patient. So look it up and said the patient was here visiting a family member, and they experienced acute kidney stone pain, and now they're coming down here because the pain was so bad they needed to go be seen at an adult ER. So we were stabilizing them. So I said, oh, okay, that's interesting. And then I look kind of back on the chart a little bit. I read this is the second time they'd done this like in the course of a week. And I was like, that's real weird that this patient would have these 2 bouts of kidney stones and need to come down to the ER. And sure enough, she got Dilaudid both times. And I was like, well, this looks fishy, right? It's just something was hitting my spidey senses there. And so I went ahead and I looked up on eForce, right? Just like I'm allowed to do as a healthcare practitioner. And so I looked up the patient, and lo and behold, I found this patient had been filling at all kinds of different pharmacies. She was using different addresses at different places. And I said, boy, this is some fishy looking activity here. So I go to the doc who is, he's a peds ER guy, right? So most of the patients do have legitimate pain concerns. And so I say, hey, did you look up the eForce on this patient before you wrote for that order of Dilaudid? And they go, no, I didn't. What's on there? And I showed it to him. And he's like, oh my gosh, I cannot believe it. She seemed like she was in so much pain. I go, well, I mean, there's some pretty good actors that are out there. And I mean, even for something like a kidney stone, right? It's very difficult to determine if someone has a true kidney stone on physical exam. You'll find that, even for things like urinalysis, they'll prick their finger, put blood into the urine sample to make it look like there's red blood cells there, right? So there's things that people will do in order to try to circumvent the system. And anyway, so then the doc was like, well, cancel that the second order. I don't know if she actually has legit pain, but she's medically stable. Let's get her shipped out of here. And she basically made a note on her chart to make sure that she never got opioids from us again because of this behavior. It was certainly does not seem legitimate anymore. But so anyway, so short story of one bad case. It does not mean every patient out there is lying. It just means that was one instance of utilizing a resource to help us identify that. You may have patients coming in saying, "Oh my gosh, I have all this pain." You look up their history and eForce, and everything looks totally appropriate. And you're like, okay, now I feel more confident that I can prescribe these opioids because I feel that they do have a legitimate complaint, right? So there are ways to use this for the patient's benefit and maybe to help stop some of the abuse that could be happening out there. Sylvina's asking, is there a country-wide tool like eForce? I wish there was, but this is all very state-to-state based. In fact, Florida was very late to get this program as compared to some other states. So unfortunately, that's not the case. If someone goes to Georgia and fills there, we don't get that information. So that can be a challenge, especially if you work up like in North Florida. Katie was saying, I used to work with a doctor who would look up history on eForce and mugshots all the time, huh? Like I said, yeah, Florida's interesting because like all mugshots are available. That's why you see a lot of those stories about Florida man and Florida woman out there in the news because we have very kind of easy access to a lot of those arrest records, which I think is interesting. But I don't know. Anyway, so questions about how does this impact you? So this is a law that actually went into an effect in 2018. Back in those. Boy, what stable times those seem like compared to now. But there was a House Bill 21 that was written into effect in 2018 and basically applied to all controlled substances. And what this did was really try to curtail how much opioids that we were prescribing, because it was not uncommon for people to go into an ER, complain of pain, and they can get like a 1 week prescription's worth of opioids, right? Which may not be appropriate all the time. And so we're trying to find ways to curtail this because we know that opioid addiction was becoming a really big problem here. So this is one way we try to curtail that. Now, this doesn't do anything about the heroin issue we have here, but this is one way we're trying to curtail it. So anyway, basically all practitioners have to take a 2-hour training course during their 2-year licensure period. So you have to renew your license every 2 years, and you have to do a 2-hour training course for this. And it says you have to check eForce every single time you're prescribing one of these opioids. Okay. Now, do they actually check for this? Is anyone doing any monitoring for this? Who knows? It may be different depending on where you're working. But that's in the law. And they said that for acute pain, you have a 3-day limit. You may be able to extend it to 7 if you write acute pain exemption on the script. But everyone just at a default is at 3, okay? For patients who have chronic pain who require something like OxyContin for the month, you have to end acute, non-acute pain. So you'd have to actually write that on the script itself, okay? Now notice this doesn't apply to inpatient orders, right? When you're inpatient as like a PA working, you're under that hospital's DEA, right? This is for outpatient prescribing purposes. So every time you have that patient in the ER, you have to discharge with a script for hydrocodone. You're looking up eForce, making sure everything looks like it's passing muster there, and then you can write for that 3-day limit for most patients. But if you need to extend it to 7, you can do that. Otherwise, I have to write non-acute pain on there. You don't have to write why they're getting a pain exemption. You just have to have the wording on there for the pharmacy to say, okay, I can fill this. Otherwise, they're going to call you up and have clarification there. Okay. So anyway, so let's talk about federal scheduling of narcotics. Actually, there's a question up here on the board. Someone says, is there a correlation between opioid addiction and workers' comp, i.e. people getting hurt at work, going to opioid prescription, going to chronic pain, going to addiction, going to heroin? That is one pathway to this stuff. And it really doesn't have to be workman's comp necessarily. It could be really with any injury. But you think about cases of more physically demanding jobs being more injury prone. Like you think about, construction jobs and things like that, where these injuries might be more likely. That could certainly be a pathway for that. I don't know if there's been any statistical analysis for that, but that's something to consider. Another thing you may not think about, and again, I'm not an avid wrestling fan, but actually Florida is a huge hotbed for wrestling. Pro wrestling. There's a lot of training camps and stuff here in the Central Florida area. Interesting enough, like a lot of those wrestlers, like they get beat up for a living, like for their job, and so there's a huge incidence of opioid addiction there as well because they have to self-medicate for a lot of this stuff. The problem though is you're going to find is that why does this stuff lead to heroin? Well, because getting access to prescription opioids becomes more difficult as laws like this stuff gets put into place. So if you don't if you have a physical dependence or an addiction to these substances and you can't get access to the prescription-based ones, then you're going to turn to something else, right? You don't just say, darn, I can't get my meds, guess I'm not going to have any. You're going to do whatever you can to try to get access to that. So that's where the heroin comes into play and can be pretty problematic, right? Okay, and so someone was asking earlier, is there any legal obligations of telling other providers? This would be likely something you would make a note of in your chart. I don't know if there's any legal obligations to say that, but you could put something in the chart that would say, do not write for opioids anymore. You could do something like that, so that way other providers would know, okay, there's been some issue here. They felt like they do not, want any more opioids being prescribed. Things like that can happen, but no actual legal obligation. Someone's like, can retail pharmacies also check E-Force before giving medications a double check? Yeah, and we should be doing that on the retail side of things, just to make sure that, people are not filling at multiple different, and I wish I could show you a printout. I don't have like a generic one, to show you, to avoid violating HIPAA, but, it'll tell you who wrote the script, where did they get it from, when did they fill it, how much did they get, et cetera, et cetera. They have all the information. So if it turns out like they filled 200 OxyContin at a pharmacy in Ocala yesterday, and now they're here in Orlando trying to fill a similar script for that would be a huge red flag. I would say, well, what, and you could take that printout to them and say, well, what happened to this 200 OxyContin you got yesterday? Let's say, oh, my dog, my dog got him, flushed him down the toilet. I said, well, I'm just not going to fill that, and that's our right, as a provider, we can decide not to fill any prescription we want. That just may mean that the patient will go somewhere else, and maybe someone would not be as diligent and just give it to them. Who knows, right? But yeah, that is part of our professional responsibility to make sure that we double check that stuff, just like you guys are responsible for doing the same, right? That's why we're a team. The team effort here, right? Anyway, so while we have a few minutes left here, I just want to talk about federal scheduling of narcotics. Remember, there's C1 through 5. I think I covered this briefly in the summer semester, but just to reiterate it, remember the C1 through 5. C1, if you recall, C1 means there's no acceptable medical use, right? It's a high risk of abuse and addiction, but there's no medical use for this. Federally, marijuana is still a Schedule 1 substance. Stuff like the bath salts, when those came out a couple years ago, that's a Schedule 1 substance, right? So if you have possession of that federally, still considered to be a felony, right? Now, states can have their own control levels too, so you may find there's a little bit of difference there. That's why you've seen some states have decriminalized marijuana entirely. Some people have made it okay for medical use, but from a federal standpoint, it is what it is, right? It's just the federal government chooses not to go after those people using marijuana in the states where they allow it, right? So it's one of the weird kind of legal issues. A C2 does have acceptable medical use and still has a high risk for abuse and addiction, right? So C2s are going to usually include most of your heavy opioids, oxycodone, hydrocodone, hydromorphone. All those drugs we're going to get into probably next time because I'm running out of time here. Those are C2. Those have the highest control with them. Remember, you can only write for like a 90-day max amount. You cannot write for refills on those scripts. It's very tightly controlled and very heavily monitored. Remember, other examples also include things like cocaine fits on the C2 list, interestingly enough, because you can use that occasionally for, ENT procedures and whatnot. But usually the heavy-duty opioids are going to be most of your C2s there. Also, if you're dealing with patients who are getting amphetamines for ADHD, those are all C2 as well. So I think I'm going to go ahead and cut it off there. We'll get into the individual drugs next time. I'm mostly done through this section here, that we can get into whatever we have next, I think. But let me see if there's any other questions here. So hopefully, if you came in late, check out the beginning of the video. I talked about the prescription assignment, how it's different. We're doing inpatient orders now. So you want to look at the second half of the rubric to get some ideas of how you want to write those orders. And I kind of walk through my mindset when I'm doing those. Otherwise, we'll see each other next week. I think that we will be meeting at 8 o'clock next week. It's our normal time. So make sure you're there for that, bright and early for us. And otherwise, if you have any questions, feel free to email me, and I'll see you guys next week. Thank you for joining me today. I really appreciate it. Have a great weekend, guys. All right. I will end the stream here. I'll see you next time.